important topic. I'm going to talk a little bit about depression, anxiety, and suicidality in epilepsy. I'd like to start by sharing a story from our clinic at Children's Hospital. So initially, my work in epilepsy was focused on surgery outcome and especially looking at memory and language outcome following temporal lobe surgery. And early in my career, I put a lot of emphasis in publishing that kind of work, looking into maximizing the outcome for, especially in pediatric populations, because of the importance of memory and language for academic performance. And one of the patients in our cohort was this young man who at the time of when the story begins is 22. When he first came through our clinic was at the age of 10 when he started having seizures. And immediately during not immediately, but as part of the phase 1 evaluation, it was clear that he was a good surgical candidate because the seizures were refractory and also because there was a lesion on MRI that appeared to be consistent with mesial temporal sclerosis. When he was evaluated for neuropsychology, at this point, he is 17 years old. He had a pretty normal profile, nothing that seemed to be outside of the age expectation. The only exception to that were some of the memory testing, and he had difficulties with word retrieval. So very consistent with the profile of dominant temporal lobe epilepsy, especially with a suspicion of hippocampal sclerosis. There were some reported concerns about his mood and frustration level. He had lost his license because of the refractory nature of his seizures and just the limitations in quality of life he was reporting. But at the time, he had not been diagnosed with anxiety, depression, or no other clinical psychiatric condition. So he underwent lobectomy at the age of 18. He was seizure-free for 3 years. It was one of the cases that we considered a tremendous success. He graduated high school and was finishing a technical program to become an electrician. And he was in the process of beginning his apprenticeship. So he had finished the kind of classroom training for that. At the time, then seizures recurred. Again, 3 years seizure-free. They recurred in the setting of poor sleep and overexertion. His mom had mentioned that he was working really hard over the summer, and just seemed to be staying up very late, waking up really early, and really starting to spend most of his time at work and making money. I was really happy about that. Again, he was 22 when this happened. So seizures come back, and some adjustments he was on monotherapy at the time. They made a few adjustments, but he continued to experience seizures every few months. And later in the fall, we get a phone call that from his mom that he had committed suicide. He didn't want the family to report that to Children's Hospital, that he had stopped taking his medication and that his seizures had become increasingly more frequent. He wanted to essentially lead us to believe that the seizures were well controlled on the medication regimen that he had been on, and had expressed the lack of desire to go through the process again, as he put it, which was basically he didn't want to have surgery again or go through the process of exploring a potential pharmacotherapy adjustment. So we, as a team, I think it was really shocking. You know, we talk about these things a lot in training and other settings, but when it's happening with one of the patients that you've been working really closely for years, I think it really hits home. And in the conversations that we were having for those evenings are the kinds of memories that I don't think I can ever forget as a clinician. So it sort of shifted my interest in as an academic from not just looking at memory outcome and language outcome, but let's explore this concept of depression, anxiety, and suicidality a lot more in our patients, because clearly there was a gap here, and we need to do better. So just to give you a little bit of background, I think most of us that have been practicing in the epilepsy world for a while are familiar with these numbers. The youth with epilepsy are diagnosed with psychiatric disorders at a much higher rate than the healthy population, and also at higher rates than most other medical conditions. The most common psychiatric disorders are anxiety and depression. Suicidality is also a significant concern with this population, but we know that suicidality increases also in adolescent and young adulthood with individuals that don't have epilepsy, just any mental condition and any mental health condition. There's a significant increase in this particular period of their life, up to 3 times more of a risk based on some studies. And by the age of 20, 7% of these patients will have a suicide attempt. So pretty alarming number. Again, for epilepsy specifically, about 20% of patients with epilepsy will experience some form of suicidal ideation. Those numbers vary depending on the study and the setting. But 20%, again, 1/5 of our patients may report some type of suicidality. And we know that up to 85% of youth with depression, with or without epilepsy, will experience ideation, and nearly 1/3 will attempt suicide as adolescents or young adults. Suicide rates in the US are increasing especially over the last few years. It's a second leading cause of death for youth in the US, at least it was by 2018. The rate for youth ages 10 to 24 increased by 57% between the years 2007 and 2018. And in these publications by the CDC and the National Institute of Mental Health, the impression is that there are some significant contributing factors, such as we know, depression, hopelessness, low self-esteem, but also the relationship with their peers and their parents, academic difficulties, and an increase in substance use, not just them, but the folks around them, like family members. There are certain populations who just seem to be at a greater risk for suicidality. Again, independent of epilepsy diagnosis, just in general, the American Indian Alaskan Native youth and folks that are biracial seem to have higher rates of both ideation and suicide attempt. And conversely, there was a decrease among most racial ethnic groups between 1991 and 2017 in terms of suicidality, with the exception of Black youth. And some of the variables that are suggested as contributors are access to mental health treatment, which Dr. Douglas mentioned earlier, and higher rates of poverty and adverse childhood experiences and trauma. Here's a graph that essentially shows these rates as they have been increasing over the last couple of decades. And this is pre-COVID. I think Dr. Douglas mentioned earlier, some of the statistics that we have for now are before COVID. We know that things have gotten significantly worse since 2020. So we can just imagine that these curves are even greater. So as of 2018, we see this is based on age. So this is the younger population in green, in red is the adolescents, and then early adulthood, young adulthood in the darker color up here. The rates for the younger population have remained relatively stable. At least the increase hasn't been as significant, between 2 and 4 for every 100,000. But we've seen a significant increase around the year 2013 for both the adolescent and the young adulthood. And folks who follow the influence of social media on the mental health of our youth may recall that this is the time period where there was a significant increase or significant change in Facebook and other social media platforms that we know started impacting our youth mental health more directly. They started talking about this in the media over the last year or so. So I don't think it's necessarily coincidental that this is the point where we start seeing a significant spike for both of these age groups. I also like to highlight the regional differences in suicide increase. The darker the color, the more significant the increase. The Northeast seems to have some of the higher rates of suicide increase over the last couple of decades. Vermont and New Hampshire were 2 and 3 overall in terms of the change and increase in suicidality. Massachusetts doesn't rank as high, but it did see an increase of 35% in suicidality over the past couple of decades. So it's certainly something that impacts the region significantly. Dr. Douglas mentioned before, there is a biology and environment interaction that we know contributes to the significant risk of increased mental health issues and suicidality. These biology factors are related to the neuroanatomic circuitry that we know it's impacted, neurochemistry, especially neurotransmitters such as serotonin and norepinephrine, and the interaction between them, the effect of environmental changes or trauma, the effect it has on the stress hormones and the production or reaction that the body has in that context, that creates a self-reinforcing mechanism that increases this risk. And I think that's part of the theory, the theories behind why early life adversity is significantly associated with suicidality. There's a reinforcing mechanism between the trauma, the changes that it has in the brain function, and how that impacts the brain as it continues to develop through childhood, adolescence, and young adulthood. So we know age is a risk factor. The risk of suicidal ideation and actual attempts increases as individuals go through adolescence into young adulthood. I think as a clinician, this would make sense to us. It's a state of transition, independence. They're forming identity. There's a lot of changing situations in their environment, in their schools, in their home. Some are planning to move out of their home, at least temporarily, going away to a new place alone for the first time, or at least away from the family for the first time. Others are not making that transition, but they're observing their peers undergo that transition. So they're staying back home while their friends are going away to college. These kinds of changes that are happening very rapidly are known to impact the mental health of the youth. At the same time, around the adolescence and young adulthood, there's a lot of physical, hormonal, and other types of physiological or biological changes that could increase the likelihood of experiencing anxiety and depression. And this is also the age where people may begin to experiment with substances such as alcohol and illicit drugs that we know also increase the risk of anxiety, depression, and suicidality. So there's a lot of factors that are happening in that particular period of development that we know could increase the risk. In addition to age, we know that there are several environmental risk factors that we need to monitor or at least be aware of, given that they increase the risk of suicidality. Trauma, as I mentioned before, especially physical, sexual abuse, but also emotional abuse. In some studies, they have found that children who are in the welfare system have a higher risk of suicidality, depression, and suicidality. I think that's more of a marker of social economic status and poverty, rather than whether they are or they're not part of the welfare system. I think it's more of an indicator of poverty and other resources that are maybe limited in that population. Adolescents that are victims of bullying or even the perpetrator of victimization can be at higher risk of suicidality and depression. The single event that may be stressful, such as the death of a family member or some other traumatic event, toxic stress, access to firearms, and other lethal means. So biological factors, as I mentioned before, we know that there's a relationship between some neurotransmitters and depression and also suicidality. Serotonin and norepinephrine specifically are the ones that are most frequently studied and cited in the literature, and the effects that they have in the central nervous system, but also the secondary effects on the HPA axis, the stress response system of the body. In some studies looking at genetic markers for depression and suicidality, they have found that genes associated with GABA and glutamate are also appear to be abnormal in individuals who have mood disorders such as bipolar or depression and suicide. So important to keep in mind that some of the same neurotransmitters that we know may be problematic or may be pathological in patients with epilepsy have also been found to be problematic in depression. So again, this kind of interaction between both conditions. Animal models of epilepsy also show that these two neurotransmitters, serotonin and norepinephrine, have an effect on epilepsy or seizure activity. Facilitate kindling and seizure foci, exacerbate severity, and intensify the predisposition in some animal models. A lot of commonalities between depression, anxiety, and epilepsy in terms of the structural findings on MRI. Studies have found reductions of the frontal lobe volumes, both in the prefrontal and orbital frontal cortex. More specific decreased volume in the right side of the frontal lobes have been found in patients who are depressed and also at risk of suicidality. But there's also subcortical structures that have been identified. In addition to cortical volume, studies looking at the tractography have also found some decreased connectivity or more disorganized connectivity in white matter tracts that connect the frontal lobes to other areas of the brain. Similarly, in functional imaging, they have found these areas, the frontal lobe, prefrontal cortex, and orbital frontal more specifically, seem to be involved in patients with, seem to be differently involved in patients who have depression, patients who have suicide. We know that we see some of these differences in patients who have epilepsy as well. And specifically, this medial prefrontal cortex and the idea behind it in these studies, their kind of theory behind why there's an impact in these areas is because of the relationship of that circuitry in regulating mood, and making decisions, and trying to gauge our response or interpretation of events around us, and trying to predict whether something is going to be rewarding or if it's going to be not rewarding, or what in the learning psychology of learning literature they call punishment, right? So these parts of the brain appear to be hyperactive and dysfunctional in patients who have depression and also at risk of suicide. So from a more brain behavior perspective, there seems to be this connection between a patient's emotional dysregulation or inability to modulate their emotional responses in the setting of certain situations or more chronic difficulties with emotional regulation. That is at the center of this risk for depression and suicidality. And it's something that we typically see with patients that have epilepsy, either directly or as a result of side effects of their medications. In the setting of the difficulties with the cognitive control of their mood, they seem to also have problem-solving deficits, and their interpretation, as I mentioned before, of situations tend to be skewed towards more negative, pessimistic, may react more aggressive, or have an overreaction to some kind of social sign that may be negative. So the brain activity in reaction to, or when they are observing angry faces, for example, may be a lot more activated in patients who are depressed, who have the risk of suicidality. So some folks have studied the relationship between neuropsychological assessments and risk of depression and suicide. And I would say the summary of those results is basically that patients with depression have a lot of executive function difficulties. It turns out that patients with epilepsy, especially younger age of onset, also have a lot of difficulties with executive function. So again, not just the biological commonalities between the two conditions, but there's clearly a functional similarity in terms of the effect of their behavior as measured by neuropsychological testing. Depression has been associated with lower performance on a number of different neuropsychological tests. Some of these may be recognizable by people in the audience. I will say, in general, they have to do with either inhibitory control, trying to inhibit an automatic response in favor of a less automatic response, or delaying gratification. Some of them have to do with flexibility or shifting between two sets. Some of them are related to cognitive organization and ability to remain vigilant in the setting of a particular task. So not a very specific type of executive task. Across the board, most of the tests that have been studied seem to show greater difficulties in populations that have a history of depression with or without suicidality. In addition, we see similar profiles in patients who have epilepsy, regardless of the localization of the focal epilepsy, or regardless of whether it's generalized or focal. Patients with epilepsy, especially diagnosed at a younger age, have a lot of difficulty with executive function. Interestingly, patients who are at greater risk of suicide seem to be performing even worse on tasks of delayed gratification, cognitive organization, and inhibitory control, these last three tasks that are mentioned here. And the folks that completed the meta-analysis, their theory is that basically there's a problem in the person's ability to control to assess value to what's going on in their life, and there's a problem in their reward or motivational system of the brain, and they can't control their behavior as a result of that. So with a little bit of time that I have left, I want to transition a little bit of the recent work that we've been doing at Children's Hospital related to this. So as I mentioned before, we had a patient that really impacted our approach towards this particular topic. And this was in 2018 when it happened. And at that point, we were interested in understanding the scope of the problem in our patient population. In other words, are we missing something here that we should be assessing more in depth, and we should be managing, maybe not primarily, but making sure that we're making appropriate referrals in the community for management. And second, what else can we be doing? Are there alternative treatments that can be available? We know some of my work with collaboration with my colleagues that do transcranial magnetic stimulation, for example, I know that folks who have epilepsy are oftentimes turned away from that alternative treatment for refractory depression because there's a concern that the TMS may exacerbate their seizures. And TMS is also not frequently authorized for or frequently administered for adolescents and young adults. And so we have a population that for various reasons may be limited in the type of interventions that could be available for depression, even in the setting, especially in the setting of more refractory depression, or the ones that don't respond well to the SSRI and cognitive behavioral therapy. So again, based on that, our first step was to get an idea of the population that we're working with at Children's. We wanted to also understand whether having epilepsy and depression increased the risk of suicidality, whether essentially the combination of these two, the co-occurrence of these diagnoses would make the risk higher than depression alone or seizures or epilepsy without depression. So we randomly selected 100 patients with depression and 100 patients with depression and co-occurring epilepsy. And we found pretty striking similarities between both groups, and none of which were statistically significant. About 69% of patients with epilepsy and co-occurring depression had experienced suicidal behaviors that were documented in their medical record. This was a retrospective chart review. I was doing with a fellow, a neuropsychology fellow at the time, and we found that nearly 70% of the patients had reported suicidal ideation to either the neurologist, the neuropsychologist, or the NP. About 50% of them had been hospitalized for ideation at some point prior to when we started this record review, and almost a quarter of those patients had attempted suicide in some form. So I think all of us were pretty shocked by the numbers. We were missing the significance of how often our patients were experiencing suicidality, because it was somewhat compartmentalized. They were being sent to community hospitals, or they were being admitted in community hospitals and then transferred to us, or they were admitted for suicidality, but then transferred to the epilepsy unit and then followed by the team there, but not necessarily as an integrative approach, or the depression or the reason for the admission may have been somewhat, it sort of changed in terms of the care. So we found that it compared quite a bit with patients that had depression without epilepsy. There wasn't, I think the silver lining of our finding was that we didn't see that the combination of depression and epilepsy increased the risk as compared to just having epilepsy. But at the same time, I think it made us a lot more aware, something that perhaps our psychiatry colleagues had known all along, that just having the diagnosis of depression or anxiety significantly increased the risk for suicidality, and therefore require a lot more monitoring. So I have a list here in my slide as I'm running out of time, just to reinforce the need for continuing monitoring of these patients. Unfortunately, I don't know if I should say unfortunately or not. Honestly, I always have trouble trying to describe this particular part. There's so much of what I read in these charts that seemed to be sudden in the reaction to go from depression, suicidal thoughts, to an actual act of suicidality. It seems so impulsive oftentimes. In the manuscript, I have these narratives of what the patients had reported at admission. And it seemed like there was a negative family interaction. They got really mad at their parents. They went outside and they did something that they just impulsively wanted to harm themselves. One was related to the loss of a family member. Another one, their dog was killed on the road. The dog left the house, was killed by a car, and that evening they made a suicide attempt. So it seemed really hard to predict when it was going to happen. And because of that, I think the approach must be more about constant monitoring and providing a lot of support as a way to prevent the escalation after one particular moment where they may have this acute response of emotional dysregulation that is accompanied by a lack of impulse control. So as a way to try to at least begin doing that, I'd like to just remind all of us that the International League Against Epilepsy recommended that all patients be screened for their mental health status at every clinic visit. For kids, pediatric patients and adolescents, it's really important to get their perspective on their mental health, but also to have a caregiver report because those are not always consistent. That's not to say that the patients aren't good subjective reporters, but there are times where they're not and the parents are, or vice versa. So it's important to have multiple reporters. The evaluation of anxiety and depression, including suicidality, should be more detailed at the onset and at least every year as they're coming through clinic. Also, we know and Dr. Douglas talked about this earlier, we know there is a relationship between alterations in mood and anti-seizure medication. So it's important to also monitor changes in mental health as it relates to changes in their anti-seizure medication. I think we should pay particular attention to patients that appear to have poor coping strategies, such as avoiding or disengaging, and also patients who have an acute change in their social support system, such as changes in the family structure, relocation from another place where they lost their social network, like their peers. Things that seem to be changes in their social system seem to be more related to suicidality. And we know that a family history of depression and also suicidality increases the risk significantly. So those patients should be screened more often and followed more closely. And a history of substance abuse, both the patient or the family history of substance abuse, has been found to increase the risk of suicidality. So these are some of the environmental and family factors that I think we should pay attention to if we want to try to tease out what patients may be at increased risk for suicidality.